Hello, everyone. Good morning. Good morning. Good evening. Good evening. Not good morning. Thank you guys for making it. I just have to make sure that all of these mics are muted. I don't want to hear any awkward conversations. Sometimes it happens. All right. So thank you all for coming. I feel like I haven't done these webinars for such a long time. Summer just seems so long. I hope that everyone is getting, back in the swing of things. Kiddos are going back to school, and hopefully everything is going well. So tonight, if you're new to these webinars, we do these webinars once a month, and it's really a way for us to just provide information to others out there. So I'm glad that you're here today. Any suggestions are always acceptable. So please, if you have any suggestions of future topics that you want to touch upon, let me know. I'm super open to it. So tonight, I actually have a very special invitee. So Melissa, do you want to tell us a little bit about yourself, introduce yourself?
Sure. Hi, everyone. Good evening. I'm Melissa. I'm a BCBA at Crystal Minds. I've been a BCBA for a couple of years now, and beforehand, I was an RBT. So I definitely have worked in ABA for a while, close to 10 years, which is really nice. And I'm excited to be here with everyone. So can't wait to start the webinar.
Thank you, Melissa. Thank you for doing this for us and with me. And tonight we're going to talk about autism or just a phase. And the reason why I wanted to speak about this is because I get so many parents when they come in to do the consultation. And I'm not sure if you also hear about this, Melissa, but I have so many parents that come in because they went to their pediatrician. Usually it's the pediatrician. And they're like, hey, my child is starting to flap or they're starting to walk on their tippy toes or they don't, they're almost two and they're not really speaking. And the pediatrician says they'll grow out of it. Just give them time. And that is the worst advice ever. That is the worst advice because early intervention is the best intervention. So, yes, we do have to allow them to grow and take mold of what's going to happen, but we also have to step in and get the proper care. So, thankfully, these parents didn't listen and came to us. And that's how we start, the diagnostic process and later on, some of the times, the ABA process. I'm not sure if you've heard some clients come to you saying that that's what the pediatrician told them, Melissa.
Yes, definitely. Especially by the time that they make it to where I do their evaluation in order to get our services started. They do have sometimes at one point a long road ahead of them before they even get to us. So once they get there, they're like, well, thankfully we didn't go that route because it would have taken a lot longer. And like you mentioned, Dr. Gilbert, and early intervention is key, especially since we do such intensive hours when the kiddos are, just turning 2 or 3. It really, really makes a huge difference. So,
Okay,
yeah.
awesome, awesome. Absolutely. By the way, for those of you who are just coming in, you can put your questions on the meeting chat. Put questions, comments. Let's make this super interactive, right? It's the evening time. We don't want a boring webinar where you're being spoken to. So please, please, please add any questions there. All right, so really quickly, the services that we provide. So at Crystal Mind to Beginning, we've been operating for already 15 years. And we provide ABA therapy. We have our preteen group, our social group. We have a really wonderful coordinator who is Jen, who facilitates these groups. And she is, if you've ever met her, you know that she is great. She's outstanding. We also provide mental health psychological services. We do psychoeducation and psychological assessments for anyone who needs a diagnosis. And we do parent coaching and also school consultations. So let's talk a little bit about early signs versus just a phase. So as a parent, how do you know if these are some early signs that you should be concerned about, or if this is just a phase that your child is going through? So some developmental delays can be part of the normal variation. Like we have kids who are shy. We have kids that are late talkers. Just that's just the way they are, like genetically. We also have kids that perhaps they haven't been stimulated enough. We saw a lot of this during the pandemic, and that's why they haven't really acquired words. But some red flags that you should really keep your eye on. are for no response to name by 12 months. If your little one is 12 months and they're not responding to name, so what do I mean by responding to name? They're not looking at you, they're not, shifting their body towards you when you call their name, then there may be a concern there. Limited eye contact or lack of social smiling. Social smiling, when they see someone, normally kids will smile. Repetitive movements or unusual fixation with certain things. So we see some of that rigidity with this is what I want. And if I don't get this, then, have a tantrum or a meltdown, or things have to be lined up, or just repetitive movements like hand flapping, tippy toe walking. I'm not sure, Melissa, can you think of any other repetitive movements?
The tippy toe walking for sure. Sometimes like rocking back and forth, excessive clapping. Those are some of the ones that I've seen.
Yeah, some other ones that are not as obvious and people don't talk about is like the grimace, something like
Mm-hmm.
where they go like this, they kind of like tense up their body and then they let go, right? So sometimes we'll see certain things like that. And it's usually when they get very excited, when they're watching like YouTube or they get very excited about something. So the key difference is that the typical phases fade with time, but autism signs tend to persist and they tend to intensify. We also see regression. So some kiddos that have words or skills, and then all of a sudden they kind of lose them. So I know that a lot of the justification for this anti-vax kind of propaganda that was going on and everything. I don't want to get into it, but a lot of it is because a lot of the kiddos normally had this regression phase right at the time where they were receiving the MMR vaccines, right? So studies have already proven that they don't, give autism, but I know it's still out there and some people still believe that it does. Alrighty, we have our first question here. Hi, if I think I have autism, do you guys do adult testing? Yeah, so we actually do. We do testing for kids, we do testing for teens, and we do testing for adults as well. I think it's interesting because a couple months ago, I had an adult come in and they were like, well, I've been diagnosed with depression, with anxiety, with all these things, but I really think that I meet the criteria for autism. And after having a conversation, I was like, I see some things, right? Let's get you tested. And then once we got them tested, he was like so happy. Like he was like, thank you. Now it makes all sense that I am in the spectrum. I'm not like depressed. I don't have bipolar disorder. I just think differently. I process information differently. So I think that there's no like late age to get diagnosis. If you need it, you can definitely, get the diagnosis. Okay, question. What if they are social but have those stimming behaviors? So what do you think about that? That's a good question. What do you think, Melissa?
I think that we should still keep an eye out for sure, just because that is a core deficit of autism. So, it is a spectrum. That's why it's called autism spectrum disorder. So, it comes in different shapes and sizes. So we do want to keep an eye out on those quote unquote stimming behaviors for sure.
Yeah, and sometimes it's not autism. Sometimes it may be like a stereotypic movement disorder, which is also a diagnosis. So it may not be autism, but that's why it's so important to go to a professional. Also, sometimes as parents, we see something as a social behavior, but it really isn't. Or it is, but not, in the way that you would expect for a child that age. So again, it's super important that we take them to a professional who's not biased and who can give us a real clear answer. Okay, so when is it not a phase? So behaviors last longer than expected for age. Again, you may be shy, so you may be a late bloomer, you may not speak, but by age 3, you should have words in your repertoire. You should be speaking, you should be asking and demanding for things. Appear in different settings. So again, these behaviors or these lack of skills, we are seeing them at home, at school, and on the playground. Sometimes autism gets so some people get confused with autism and selective mutism. And I think that this second point is super important for that because in selective mutism, the child chooses to be mute. So let's say in a school setting, they are not speaking, they're not interacting with friends, they're being mute. However, in the home setting, they speak. They speak perfectly fine, right? So that is the main difference. With autism, we see the same level of skills across the board. We see it at home, we see it in school, we see it in the playground. Interferes with learning, socializing, or daily functioning, do not improve without target interventions. And again, I will say it once and once again, and a lot of times, early recognition leads to early intervention, and there's better, stronger outcomes. Okay, so parents' perspectives and myths, and I want you to tell me, Melissa, if you have heard any of these. So some common thoughts that parents may have, and they may say is, well, he'll grow out of it. He'll grow out of it, it's fine. Or her cousin was a late talker too, or boys talk later than girls, or something along those lines. What do you think about that?
Definitely have heard those from parents. I understand that everyone's different, right? And there are certain things that people do grow out of, right? Like we mentioned, you go to your pediatrician, they'll tell you to give it some time. But like you mentioned, Dr. Gilbert, these things do persist and they get more intense over time. So it is understandable, but definitely some things that are still perspectives that maybe we can turn around.
Yeah, absolutely. Okay, we have another question here. Are there different types of autism? So we will get to that right now. Let's do a little true or false trivia. And I want you guys to put it in the chat whether you think it's true or false. Let's see. Okay, so for those of you coming in, we're doing a true or false trivia. All right, so the first one, autism falls in the category of neurodevelopmental disorder along with ADHD and ID. What do you guys think? True or false? I wish I had like that timer, like ticking song. Okay, I see true, true. Well, this one's easy. Yes, so autism falls in the neurodevelopmental disorder, and this is what it looks like. So, neurodevelopmental disorder basically means that this is something that you can say you were born with, right? It's not something that you acquire. You don't acquire autism later on in life. You don't acquire ADHD later on in life. You can have like a brain injury, or you can have like medication induced disorder or something like that that may mimic some symptoms of each of these disorders, but you won't get diagnosed with this because you didn't have it in a very early age. So neurodevelopmental disorder is sort of this umbrella, and we have ADHD there, we have autism, we have intellectual developmental disorder, which used to be called oh my God, what was it called? Mental retardation. And then we also have specific learning disorder, motor disorders, communication disorders. And part of the communication disorder is social pragmatic communication disorder, which I'll touch upon later on. So, next, true or false? Let's see if you guys get this one.
We have a question in the chat.
Oh, we do. Oh, let's answer this
Yeah.
question first. I prioritize my questions. Let's see. But what if an adult was never diagnosed as a child because her symptoms came up in adulthood? That's a good question. So if there's symptoms, this is a little tricky because sometimes if it's an adult, the parents may not remember, or the parents may not be willing to share. So it's hard to know if they had these symptoms early on. So those are situations where it gets a little tricky. However, again, it's a neurodevelopmental disorder, so you cannot all of a sudden have autism, like, symptoms like that. It doesn't happen. You wouldn't be in the category of autism. You wouldn't be diagnosed with it, if that makes sense.
I have a
Right.
question, Dr.
Yes.
Gilbert.
Sure.
So, what would you say is the biggest way to discriminate between these three neurodevelopmental disorders,
Okay, good.
especially for autism?
That's a good question. So ADHD, ID, and autism.
Hmm.
Okay.
Yeah.
So ADHD and autism, it used to be that you couldn't diagnose both of these disorders, but newer research has pushed us into, yes, you can. So like the newer DSM-5 and the DSM-5 TR, which is what we use to diagnose, tells us that we can, but we have to be very careful because there's a lot of overlap. So I think that the main thing is what is the function and also the frequency of the behaviors that we see in each of the diagnoses. For example, when we see a child with ADHD who is like, kind of like squirming in their chair and is kind of like just walking all over and running, right? We can say that he's doing it for sensory purposes, right? To regulate. However, with autism, that repetitive movement that we kind of see in ADHD, it's more of like a repetitive movement that doesn't stop, right? So it's like an ongoing repetitive movement, and it just seems like it doesn't stop. Okay. So that's one of the differences. Also, in ADHD, you may see some hyperactive disorder, some hyperactive behaviors that you won't see in ASD.
Got it.
In intellectual developmental disorder, it's more linked to like a lower IQ. So you won't see repetitive behaviors in ID. You won't see like the lack of social behaviors or the repetitive behaviors that we naturally see in ASD. You won't see it in ID unless they have both.
Got it. Okay.
Okay. Also, for ADHD, we don't see the deficits in social interactions, like not understanding social cues and things like that. We don't see that in ADHD. But that's a great question. Okay, so autism is a new fad and everyone is now diagnosed with it. True or false? What do you guys think? This used to be the thing for like ADHD where they were like, oh, everyone has ADHD. Okay, false, false. Someone is really passionate about false. They're like, false. False. Okay, so there was no autism diagnosed before 1930. Pluto wasn't discovered until 1930, but I'm pretty sure it has been there the whole time. I love this because just because it wasn't diagnosed or we weren't aware, it doesn't mean that it wasn't happening, right? There's a lot of cases of autism, like even adults with autism that are coming now and are getting diagnosed now because they weren't diagnosed before. What are your thoughts about it, Melissa? Do you think it's a fad or do you think it's something that's just happening?
I think definitely this is false. Uh, like we mentioned, things can be there, especially in, in ABA specifically, we see things all the time, we observe things all the time, doesn't mean that they're not happening. But just because we're not defining them doesn't mean that they're not there.
Absolutely. Yeah. And I think that now there's more awareness. Before you would say autism and people were like, what is that? I have no idea what that is. Nowadays people are aware at least of what autism is, and there's more like movies, which I don't necessarily like autism in movies because I think they do a very poor job in portraying autism, and then people think that, oh, everyone with autism is a savant or everyone with autism is like this, and it just creates more of that stereotype. But definitely now we're more aware. Okay, so the diagnosis, by the way, of autism, is I like to say we have like two main categories. So just so you guys know, it's not a fad, and there's actually criterias that you have to use in order to get the diagnosis. When we do the ADOS, which is really the gold standard for diagnosing autism, that's the test that we use in our clinic. And when we use that, we're able to test all these different things to see if they meet the criteria for autism. So the two main categories, the first one is social communication. So an inability or difficulty or deficit with social communication, with understanding back and forth conversations, with knowing how to change or maintain the eye contact while you're having these conversations, and sometimes not even having conversation, so not being able to communicate verbally. So the first part of it is this lack of communication. The second part of the diagnosis is the stereotypic behavior. So hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So sometimes a question that I ask is, how does your kiddo do when they're walking in the grass? Or how do they do when they're walking in the sand or when they hear a loud noise? Some parents even tell me he can't wear certain fabrics or certain like tags because it bothers them too much. So these are all important things to look at. Now, just because this child is bothered by closed tags or whatever doesn't necessarily mean that they meet the criteria for autism. I think overall it's this inflexibility. You see the rigidity, like it has to be this way. You know, things have to look this way, it has to be this way, and if not, that I have an entire meltdown. Those are like the more obvious signs that we see. How about you, Melissa? What are some other signs that, and I like to talk about the subtle signs because I feel
Mhm.
like the obvious ones, like we see them, but what are like the other subtle signs that you have seen with the clients you work with?
I think difficulty interpreting or understanding figurative language, that's a
Hmm.
big one. The other one is I see it often. I know that, some kiddos have difficulty sharing, but it's about the intensity in which, it results into either maladaptive behaviors or, an emotional response from them. Um, Difficulty with abrupt changes in routine as well, even if it's something as simple as leaving 15 minutes earlier or later. Um, and fixation on specific items
Yeah.
for long periods of time. Those are definitely some that I've noticed.
Yeah. And sometimes it's not only items, it may be a person. So I've seen it, for
True.
example, I had a teen client like a year ago that had this fixation on this one friend. And it was like the entire thing was like this one friend. She only spoke about this friend, and everything was this friend, but it was like too much. It was just about this friend. So sometimes it's just, it can be an item or also specific people.
That's true. Yeah.
Okay, we have a question here. Seems a lot like OCD. What's the difference? Good question. So what's the difference between OCD and the repetitive behaviors that we see in autism? So they do seem very similar, and sometimes it's difficult to diagnose one or the other or even like both. It can be comorbid. So one of the differences is that with OCD you have this obsession and then you have the compulsion, which is the behavior. Usually it is ritualistic, which is like what we see in repetitive behaviors of ASD, but it's usually targeted to something. For example, like I don't want germs, right? I'm scared or I'm fearful of germs, so I'm going to do everything to get rid of germs. So it's more of that cognitive kind of like fixation, and then we have the compulsion. With ASD, it's more of this repetitive, I'm providing myself with this stimulation. So it's more of a self-stimulatory kind of behavior. I'm providing myself with this stimulation or I'm getting away from this stimulation. With OCD, the function or the reason is a little bit different, if that makes sense. But it can be a little difficult to differentiate the symptoms of one and the other because when you see them, they look very similarly. Also, with OCD, there's usually like a number. So I'll turn off and on the light 7 times, right? And it's all like a pattern that's like that. So you don't see so much of that physiological reaction that we see in OCD. Okay. One, two questions. Can I choose Kava? Okay. So another question here is what therapy approaches do you recommend for autism in children and adults? That's good. So ABA definitely if there are skill deficits or maladaptive problematic behaviors. CBT, individual therapy is also a good one. Group therapy. So I've seen a lot of gains in our group therapy group, more so for preteens and also for adults because the preteens, some of the things that we've heard is that they don't feel identified, they don't feel accepted, they don't feel like other people are they feel alone. Today I was speaking with our program coordinator and she was like, oh my gosh, a lot of these kids are saying that they feel alone, like they don't have a voice, like they want to be like others but they're not accepted. So I think in a group where everyone has the diagnosis and you can talk freely about it and you're open and you feel accepted is such a great thing to do. What are your thoughts, Melissa?
Definitely. I have quite a bit of clients in that preteen group, and most of them, like you mentioned, are kiddos that have a hard time, especially like in school settings or just sustaining friends just because others aren't, maybe they don't have the awareness, especially since they are kiddos. So it I do think that the group therapy definitely helps, and it creates a sense of community for them as well. For everybody that has, either a diagnosis or that doesn't, they're coming together to, experience a community with people of different walks of life, but people that understand them.
Yeah, yeah, absolutely. And I think there was a question that was about the different types of autism. So this isn't really different types of autism. I'm not crazy about these levels either. I don't necessarily love them, but the DSM-5 started with the three levels of autism. So I don't know if you guys remember, but back in the day, we had Asperger disorder, we had PDD-NOS, we had the childless integration disorder. So we had all of those, and Rett's disorder, and everything got just kind of coupled together with in the umbrella of autism spectrum disorder. And some kids that had, for example, that met the criteria for Asperger's do not meet the criteria for autism now, just because they don't have all the different behaviors that are associated with it. So instead of that, the newer DSM has three levels of autism. So you'll see, when you see psychological reports, if they are credible, of course, you'll see the levels of autism next to the diagnosis. So level 1 is for a child that requires support, some support. Usually this child is verbal. Maybe they need to work on some of the social kind of goals. Level 2 is a child that requires substantial support. And then level 3 is for a child who requires very substantial support. And I say child, but I really mean teens and also adults. So these are the different levels. And according to how they appear in terms of like the clinician's eyes when she evaluates them, and also when they do a formal testing like ADOS, they're able to come up with the level of the child. What do you think about these levels, Melissa?
I think it's difficult, just because, like I mentioned before, there is a spectrum, and it's understandable because we do like to categorize things just to have clear set of criteria and things like that. But there's very small differences between the different levels. Like, how can you tell if a person falls under a specific level if they have a range of
Yeah.
different symptoms? I think that's difficult to box in.
Yeah, definitely. So the ADOS assessment actually tells you, it doesn't tell you what level, but it tells you if it's mild, moderate, or severe. So it kind of gives you that information, and then you just have to use your own judgment in order to give the diagnosis. That's why it's super important that if you guys are going to a clinician that does the ADOS, that person, that clinician also has experience working with autism, because going through a book and all of that's not enough. You have to work. And I'm not too, again, I don't like these levels. And whenever I am giving the feedback to the parents, I tell them just because they're in this level doesn't mean that they're going to stay in this level, right? Again, there's not a lot of research on these different levels of autism. We have a question here. Do the levels let you know how they will progress in therapy? Absolutely not. Every child will progress in therapy. I really think so. I think if they have a good team working with them, if the parents are on board, if the school's on board, every child will progress. I don't want any parents who think that, oh my gosh, my child is in level 3, they're never going to make a change. Absolutely not. Yes, they can. Okay. Don't get stuck on the levels. Another question: what is the difference between ASD and Asperger's? Good question. I think, let me see. Okay, I think I removed that slide. But so Asperger's does no longer exist. The newer kind of like Asperger's diagnosis is called social pragmatic communication disorder. A lot of people don't talk about it. A lot of people don't have knowledge of it. Clinicians don't have a lot of knowledge about this diagnosis either. But it's basically very similar to autism in that you need the nonverbal. So these are individuals who have difficulty understanding like jokes and also like nonverbal communication and more of that, but they don't have the stereotypic behaviors that we see in autism. Okay, so we'll see the rigidity, we'll see not understanding social cues. We'll see all of that in the social pragmatic communication disorder. But again, we won't see the repetitive behaviors that we naturally see in autism. So they wouldn't meet criteria for autism, they would meet criteria for social pragmatic communication disorder, which is the new like Asperger's disorder. What is the evaluation process like? Okay, so the evaluation process is usually you have a consultation with the clinician. That's the way that we do it in our office. And then I'm the clinician you have a consultation with. And then we do a number of different testings. We do the ADOS testing, we do the BASC, we ask developmental questions because again, we want to make sure that the symptoms have always been there and it's not something that just happened. And after that, we put everything in the system, we plug in the numbers and then we write a report, and that's really a really fast forward way that we do the reports. It takes about like a month, 2 months, depending on how full we are. And I know that other places there are waiting lists and things like that, but that's usually the way that the evaluation process goes. Is there a wait list? So we currently do not have a wait list. I think our next appointment is at the end of September. So right now we don't. Can testing do rule out ASD be done at any age? Yes, absolutely. As I mentioned before, we can test for ASD at whatever age. You can be 99 years old and we can still do it.
Mhm.
Keep the questions coming. All right, true or false? Let's see. ABA is only for children with severe behaviors. What do you guys think? True or false? What do you think, Melissa?
Think definitely false, for sure.
Yeah. What do you think about this? I don't know if you've heard about, people talking about ABA only being for severe behaviors. I've heard things along the lines of, oh, but my child just has social deficits. They don't really need ABA. They behave well. And I'm like, well, actually, I don't know if you've heard it.
Yeah. So I think that ABA can be used to alter really any type of behavior. And sometimes when we look at social interaction, we don't think of it as responses or behaviors, right, in the scientific way, but it can be, right? We as people have been conditioned to even respond to our own names. So ABA is everywhere in the world. It doesn't just affect people that do go to therapy. We It's happening all around us, we just don't notice it.
Mhm.
So some of the principles that are occurring in the real world, we just take those and then systematically apply them in therapy to help out with those deficits or any lack of skills that we have.
Yeah, absolutely. And there are people who have stolen ABA into their own kind of therapy. So we see it everywhere. Like when I was doing my doctorate, I was learning about all these like different like theoretical constructs and also like these different interventions. And I'm just like, this is ABA like with a different name. Like that's what it's basically ABA, right? Like ACT and everything, like these are all ABA, kind of things. So I think that it's exactly what you said. And also, if you're a teacher, I know a lot of the teachers always come to these webinars. You guys are using ABA. You're using this, with your kiddos. You're shaping behaviors. You're teaching things. You're providing SDs. Like you're doing it all the time, right? We just haven't categorized it. We haven't given it a name. Let me see. What other questions? Since the focus on skill acquisition, this could be applied as treatment for any other disorder, not just behavioral reduction and extinction. Absolutely. Yes, absolutely. Like when I work on with my clients, when I do more of like a behavior activation, for clients who suffer from depression, we do a lot of ABA like, strategies and we do reinforcement and we do things like that. So definitely. It's not only for maladaptive behaviors, it can also be for skill increases and improvements. So, Melissa, do you want to talk a little bit? I've been talking a lot of the time, so I want you to also have a voice. So, tell us a little bit about ABA, how ABA can help autism. Like, tell us a little bit about all that.
Yeah, so as you guys can see there, ABA, at least the therapy that we are currently implementing, especially with the kiddos that are on the spectrum, we individualize those skill acquisition goals and treatment plans, meaning that we tailor it to the person. We're not necessarily looking at it from a bird's eye point of view. We really look at the person that's coming in for treatment, and we give them like a whole plan based off what their needs are. And then when we say functionally based, we really mean we target the reason that these maladaptive behaviors or any skills are or aren't occurring. So we really dig deep as to why is little Johnny, crying, when certain things happen, or what is it about, what is difficult about holding a pencil for some kiddos to write on a paper, things like that. We really look at all aspects of the skills and the behaviors that we're targeting. And then that's just basically what it means to be functionally based. And of course, like I mentioned, ABA is happening around us at all times. So when we talk about antecedent and consequential interventions, and I say that with quotes because, again, like I mentioned, whether we implement it or not, it's occurring around us. We typically, within the ABA therapy, try to contrive these opportunities that might not come up naturally, or that might need a little bit more of a contrived push, I guess you can say. So, for example, changing the environment, teaching new skills, meaning like, let's say we're teaching hand washing, right? We try to make it as naturalistic as possible, but we might try it like 2 times within the session versus 1 time that it would naturally occur in. And then, of course, our big replacement behaviors. So, when we are starting treatment, we look at the behaviors that we want to target for reduction, but also we want to improve, right? And those are the behaviors that we call replacement behaviors, meaning that they would essentially, hopefully, replace the responses that we're trying to decrease, right? So, like it says there, it teaches on focusing new skills. It's not just about decreasing these target behaviors, which I know that a lot of critics of ABA tend to say, oh, we're making like robots out of kiddos, and that's not necessarily the case. We're trying to give them the skills that they need to be as independent and expressive as possible.
Absolutely great. Yes. So I have a question here. Why do we need multidisciplinary goal occupational therapy physiotherapist team to treat a child with autism? I think that's a great question. What do you think, Melissa? Why do we all need to, I guess, be on the same page and work together?
I Well, first, I think that each clinician brings a different perspective, right? And maybe there are some goals that require um how do I say a mix of interventions or plans. It also depends on what specifically you're working on, right? So obviously occupational therapists, they look at it more from a movement perspective, right? Versus us as BCBAs or RBTs, we're looking at this more as a whole response. So I think it's definitely important. One, for collaboration purposes, everybody kind of needs to understand what's our main goal here. And then two, I think that different clinical perspectives are a game changer. You can get so creative when you speak to other clinicians.
Yeah.
It's awesome.
I remember I was working with this kiddo who had a lot of like sensory like behaviors, and it was just difficult for him to learn to communicate, for him to learn anything, because it was so like he needed all this sensory input. And I remember working with an OT and we were working together at that time. And the OT actually used a brush, which was the first time that I've ever seen. I was like, why are you using a brush? And then she explained why the brush was so important. And then we started using the brush prior to our session, and it was great. We were able to then start working on teaching communication skills and teaching this, because he was more relaxed. He wasn't really seeking that sensory input so much. And that is an example of why it's important to collaborate and work with other individuals. Same as individual therapy. Sometimes we have a sister company, which is Crystal Mind Psychological Services. Sometimes our kiddos are being seen for ABA and they're also going into the psychological services for mental health treatment. And I always ask those two therapists to collaborate and meet together because there's so much that comes from those treatment meetings.
We
Okay,
have a
so
we have another question in the
yes,
chat.
another question here. I love the question. So, can you outgrow ASD? This is a bit of a controversial question because if we think about ASD and we think about all the behaviors that, or all the criteria that has to be met, it's really based on behaviors. And if we're able to work on these behaviors, then do they outgrow ASD or not? So technically they don't. Once you have, or once you're diagnosed with autism, then you're going to have autism for the rest of your life. You're just that's going to be, the disorder that you're going to have. However, the diagnosis you're going to have. So the interesting thing about this though is that I had a kiddo where they did the ADOS assessment when he was like 2 years old, and he met the criteria for autism. And we did ABA for like, I don't know, 3 years. And then the mom went to another state and she did the ADOS assessment there with a different clinician, and he did not meet the criteria for autism. So did he outgrow it? I don't know. Did he mask it? I don't know. But that was really interesting to see that, right? So he technically didn't meet the criteria for autism anymore. But he did also receive very like intense ABA therapy, and we were working in all environments and doing things like that. So I'm not sure. What do you think about this this question, Melissa?
I think it's tricky because, like you mentioned, the criteria is so based off of behaviors and responses that typically you can learn, right? So once you learn something, you can't really unlearn it. So it's I think it's a really tricky question. I would say outgrow is an interesting word too, because if you look at the skill deficits or things that can use improvement, then yes, in a way, but really, ah, I don't know. I think
Yeah,
that's a really good question. I guess I
yeah.
would have to say I'm not sure.
Yeah, I feel the same way, and it's okay to say you're not sure because I feel the same way. We have another question here. Using ASC can reduce the verbal communication of the child. So communication devices. Also, I'm going to throw PECs in there, sign language and all that. So research has shown that by using PECs, so the little cards, the picture cards, sign language, or even AAC devices that does not reduce verbal communication, actually enhances it. However, when used correctly. So we always
Mhm,
have to prompt communication somehow. We always have to expect language. It does allow the individual to understand that communication, however they're communicating, will get them access to something. So they're more likely to engage in some sort of behavior to get, to communicate what they want, if that makes sense. So that's what the research has shown. It's interesting because when I've done this with both of my kids, and of course my family members, they were like, why are you doing that? But both of my kids, before they even spoke, they were already signing. So I taught them sign languages, and I taught them sign, like very basic sign language, like more, give me, all done. So I would teach them that because they would have less tantrums if they were able to communicate. So that was even before they started speaking. And then they started speaking and they stopped sign language because sign language takes more effort than actually speaking for them, right? So it just naturally, goes away. Okay, I have a question here, I think, or a comment. I think AAC devices could push the developmental speech when used correctly, but it always depends on the child, absolutely. And the professional must be sure to fade it out eventually to prevent prompt dependency. That is such a good point because, yes, professionals have to remember to fade out. We, as ABA therapists, shouldn't be providing 30 hours forever. Like, we should be fading out our hours, we should be fading out ourselves, our help, all of that. We should always be fading out. And even as parents with kids, you have to be fading out and allowing them to become more independent. If speech says one thing, but ABA says another, what do you do? Believe ABA. I'm just kidding. I'm just kidding, speech therapist. I don't want any hate mail because of this. So what do you think, Melissa, what do we do if there's like this disagreement, I guess?
I think that it's a good opportunity to have a meeting or maybe collaborate with the speech therapist, just to see what it is that they have to say. And then at the same time, we can also vouch for, the interventions that we've been using, and try to find a middle ground. I will say this, specifically with speech therapists, I've gone and to one of the sessions that they've had with one of my clients, and I walked away with from that session with more resources than I came in with. So I think it's a great opportunity to just collaborate and maybe learn something new. Of course, if you have a clinician that has worked with AAC before, and we've had effective practices show that there has been improvement in communication, definitely take that into account. But it's a great opportunity for both of your clinicians to meet and to collaborate. That
Yeah.
I think that's the best way to go about it.
Yeah, I think that that's great. And also, you mentioned something, and I just want to double down on that, it's important that we see conflict as an opportunity to further communicate and collaborate. Don't see that conflict or that resistance as like, oh my gosh, I'm going to walk away. No, see it as like, you know what, let's kind of talk about this. Maybe you have good points that I haven't thought about. So yeah, I think that that's great. Let me see other questions. How early can a child be diagnosed with ASD? The earliest that I have diagnosed is 16 months. So that's the earliest that I have diagnosed myself. I have seen some, symptoms or some, parts of autism earlier, but I haven't diagnosed that. So that's the earliest that we have. Is parent coaching a requirement by insurance companies? So it is. Um, Actually, some insurance companies will stop services, they audit us, they look and see if we are using the parent coaching sessions. I know our ABAs are always pushing that. And if our parents are seeing this now, it's not like we want to just be annoying, but we want your services to continue. And also because we think it's important. We have to provide parent coaching and teacher coaching and all of that coaching. So everyone is doing the same thing. Okay, and I think that's it for the questions. Okay, so again, going back to ABA, we also work on self-care, vocational skills. So we have an adult vocational skills training that is based on ABA in our clinic, and it's great because we have adults. I know that a lot of the times parents are like, wow, my child is now out of high school. What do they do? How do they get a job? So it's not that simple. We have to work on these skills. We have to work on communication skills, on what to do when a coworker pisses you off, right? On what do you do when you're frustrated? You can't just walk out. You can't just elope. So we do work on some of these skills as well during our group. Anything else you want to add to this, Melissa?
So sure, just some examples of some of the household chores or the play skills, and specifically the self-care. So as you can see there that they put dressing, toileting, and feeding themselves. Dressing can encapsulate so many things. It's something like putting on their jacket when it's cold outside, even differentiating whether it is cold outside to put on a jacket. That's something else that we can do, right? Household chores. I have this client currently that we are teaching him how to load the dishwasher, how to separate his laundry as well. So, those are just some small examples, a little glimpse into some of the skills that we work on. And then of course, play skills. The easiest thing to think about are school age kids that either are like in pre-K or a little older, but I've had an adult client that he plays video games, and we've also had to touch on, internet safety with
Mm.
with these play skills because a lot of gaming occurs online. So there is a whole world to
Yeah.
to work on with ABA for sure.
Now that you mentioned that, I remember we worked with one of our clients. He was being catfished. So he was an adult and he was being catfished online. And the program was basically like how to differentiate when someone is being truthful or not, and how to not be gullible, basically, right? And that's very difficult because it's so abstract. But that's really what we worked on with him. So identifying when someone is trying to trick you and when someone is trying to be your friend. So right there, that's a goal that we can work on in ABA. If autistic kid is not cutting their nails and hairs, what are the techniques that we can use?
Hmm. Like they don't have tolerance for it is
Yeah, so do you mean
I'm
like
assuming.
tolerance? Tolerance based, or they're just not doing it like on themselves? Like self-care sort of skill. So tolerance based, I actually, our program coordinator had this idea like in the middle of the meeting, as she always does, but she's very creative, so I appreciate it. She was like, "Why don't we do like once a month, like a barber shop kind of thing, right? In the clinic where we have someone who specializes in autism and can help and can collaborate with us, and we teach some skills, and then this barber helps the kiddos, like with hair cutting or even like doing their nails and things like that." And I was like, wow, that's a good idea, because a lot of the kiddos are fearful of going to these places, and these places don't know what to do, right? They're scared themselves because they've never, cut a child with autism like hair before, and the child's crying, they're having a tantrum. Yeah, so if a kid started crying to the extreme when they're cutting their nails and doing that. So what kind of programs, Melissa, have you used when it's a child who sees like cutting their hair or their nails as aversive?
So usually I've more so done haircutting. I will start off with just the sound of the tool that is being used and turn it on for maybe a couple of seconds, see if they're okay with it, and then try to elongate that process as much as possible. Then maybe even them with safety, of course, trying to touch the tool that is going to be used, just getting them exposed to it, but in a way that is not abrupt, in a
Mhm.
way that they can prepare themselves for and then slowly introduce it. If we go cold turkey, that's typically not the way to do it. We definitely want to introduce it slowly.
Yeah, yeah, slowly. And it's sort of like a phobia. So when you're working on a phobia, you don't just like throw the person into that phobic atmosphere. You introduce them little by little. So it may be like a picture of someone getting
Hmm.
their hair cut. It may be then a video. It's that progressive approximation to like where we want them to go. Maybe visiting the barber shop a couple of times so they're desensitized to it, right? Hey, let's go to the barber shop, say hi, and then we'll go get ice cream or something like that, right? So the next time, hey, we're gonna cut your hair now, get ice cream, whatever, something like that. So it desensitizes it a little bit, just like with the cutting of the nails as well. Any other questions? So we have about 7 minutes left. So if you guys have any questions, please put them here. I'll finish up the webinar. And if you guys have any other questions, we'll answer them. So if you've met a person with autism, you have met only one person with autism. I always like ending with this because we have to remember that just because someone has a diagnosis, it doesn't mean that they're boxed in like everyone else, right? Everyone is an individual. They have their own set of struggles, set of challenges, set of skills. So we have to treat everyone individually. What do you think about this quote, Melissa?
So I have to agree. I also think that, like you mentioned, everyone is different. So even if you have met someone on the spectrum, you can meet another person on the spectrum and they can be completely different. Um, Bringing it back to how media portrays autism, I think that's also something else that we tend to not glamorize per se, but it presents a specific type of person on the spectrum, and that's not necessarily what everybody is like.
Mhm.
So I definitely have to agree with the quote. We have to make sure that we see people as individuals instead of, just the diagnosis.
Right. Okay, perfect. Okay, we have here, I think, a comment. I had a client with the same problem. What we did was exposure to the materials and using social stories to prepare the client on what to expect in the setting. Visuals also can help, and having a routine on each step that will take place. Thank you, Beatrice. Yeah, this is so good. What is the best way to deal with parents when they feel that autism is a pass and the child should be treated special? Okay, so that's a
Mm.
very that's a very good question. We have 5 minutes. We'll try to kind of unravel this. But what are your thoughts, Melissa?
I think there's a fine line, right? Because obviously, we we never really know what the parents might feel in terms of the diagnosis, right? That's very sensitive information sometimes. And although, the the diagnosis might come with specific deficits, it doesn't mean that there isn't room for growth and for improvement. So I think I would just take it back to, let's try to improve this person's quality of life as much as they can, especially with their own independence. And also, bring it back to, if we want other people to be reciprocal to the child or the client, right? We want to make sure that the client is engaging in some of these behaviors that will lead that to him, or her, right? So I I think it's a fine line because, like I mentioned, the diagnosis does come with certain deficits and things like that, but I think there's always room for improvement, especially when you have a really good clinical team behind you.
Yes, absolutely. And for the parent, if you're sitting with a parent that is like, "Oh, my child has autism and they should be treated special and things like that." I would kind of process that with the parent, not now, but think about in the future. So, let's think about what that impact will be like. So what happens if your child is treated special? What's going to happen when he goes to a job? What's going to happen with this? What's going to happen to him being independent, right? So run those scenarios because it's important to see the consequences of doing this. And sometimes using the diagnosis as sort of like this cradle or this thing that doesn't allow the child to really blossom can become an issue. I have this conversation with parents when we're doing like the psychological evaluations, when I'm giving them the feedback whether the child means autism diagnosis or ADHD. They always ask me, should I go and get an IP? And I always tell them the same thing: does your child need it? If your child does not need it, don't do it. Right? What's the point of just using the diagnosis for this when they really don't need it? The point is that we want them to become independent regardless of the diagnosis. Um, okay, a lot of questions, but we really have to close. Is it true that girls are different? Yes. So there's more research on girls and the way that they mask a lot of the symptoms of autism. Again, girls and boys are socialized differently. We expect different things. There's tons of studies on that, on preschool teachers, how they expect different things from boys and girls. So, for example, if a boy is like still and quiet and not running around, the teacher is going to be more concerned and bring that up to the parents. So the parents more likely to get them the help that they need. Now, if a girl is sitting down and she's quiet, usually there's not a lot of concerns with that, right? Again, we're socialized differently. So there's a lot of like missed autism in girls. Are we allowed to post in LinkedIn like we have attended a seminar? Yes, of course. Post away, tag us, take pictures, whatever it is, even if our faces look like goofy while we're speaking. I'm sure we'll be okay with that. So we're at the end of our webinar. For those of you who came in through the link for Zoom, you can take a screenshot of this and join our newsletter where we send one newsletter every month. And we also do one webinar every month. And if you have any topics that you want me to speak about, let me know, send me an email. Thank you guys for being here. Thank you, Melissa, for also joining me today and just spreading all your great information. I think you are a great clinician and you have such
Thank
great
you.
clinical information.
Thank you for having me.
And for all of my CMNB therapists that came, thank you guys for always, being here and asking the questions and all that. I'll see you guys on the next webinar.
Bye, everyone.
Bye.